Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Natharua, a clinical pharmacist by training and profession, who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Natharua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 138 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, EAO, a 44-year-old male patient is diagnosed with hepatitis. He is otherwise healthy, he remains asymptomatic. My question to you is, which of the patient scenarios listed below would meet the criteria for treatment initiation in EAO's case? Would it be A. HBeAg, negative, with HBV DNA of 7,456 IU per milliliter, ALT of 24 units per liter, and a fibrosis score of F0, or B. HBeAg, negative, with HBV DNA of 1,743 IU per milliliter and ALT of 207 units per liter, or C. HBeAg, positive, with HBV DNA of 72,743 IU per milliliter, ALT of 37 units per liter, and a fibrosis score of F0, or would it be D. HBeAg, positive, with HBV DNA of 32,875 IU per milliliter and an ALT of 152 units per liter? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. HBeAg, positive, with HBV DNA of 32,875 IU per milliliter and an ALT of 152 units per liter. Option D is correct. Based on both the AASLD and EASL guidelines, patients with a HBV viral load equal to or more than 20,000 and ALT more than 2 times the upper limit of normal, abbreviated as ULN, according to AASLD guidelines, or HBV DNA more than 2,000 and any ALT elevation and at least moderate fibrosis with HBeAg, positive, meet criteria for treatment initiation. Option C is incorrect, because while HBV DNA is elevated, the patient's ALT are within normal limits and the patient does not have fibrosis in those with HBeAg, positive, and therefore this patient does not meet the criteria. Option B is incorrect, because for a patient with HBeAg, negative infection, treatment should be initiated if HBV DNA is more than 2,000 and any ALT elevation, according to EASL guidelines, or HBV DNA more than 2,000 and ALT equal to or more than 2 times the upper limit of normal, according to the AASLD guidelines. This patient does not meet that criteria. Option A is incorrect. Based on the laboratory values, patient does not meet criteria for treatment initiation. Let's advance to the next question. And the next question reads, FTY, a fairly healthy 42-year-old male patient was recently started on rifampin, isoniazid, pyrazinamide, and ethambutol, abbreviated as RIPE, therapy for active tuberculosis. Your gastroenterologist plans to initiate him on hepatitis B therapy. So my question to you is, which of the regimens listed below would be the most appropriate to initiate FTY on? Would it be A. tenofovir disoproxil fumarate, or B. tenofovir alafenamide, or C. lamivudine, or would it be D. adafovir? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. tenofovir disoproxil fumarate. Option A is correct, as this is a first-line recommendation for the management of HBV in the AASLD and EASL guidelines. While tenofovir alafenamide (TAF) could be considered, the use of TAF with rifamycins are contraindicated. Plasma AUC of TAF is reduced by more than 50% when combined with rifampin. Option D is considered an alternative agent, as is option C. La-mivudine is noted to have high rates of resistance after 1 year of use. Option B is contraindicated with rifamycins and should not be used in someone undergoing TB treatment with RIPE therapy. Let's advance to the next question, please. And the next question reads, what education should you provide to FTY when starting HBV therapy? From the options listed below, should it be A. Take this medication at least 2 hours before or after meals because food delays absorption of the drug, or B. This medication can worsen depression, so report any mood changes to your health provider, or C. Do not stop taking this medication because it could result in worsening of hepatitis B infection, or should it be D. Frequent lab monitoring is required because of the risk of bone marrow suppression? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Do not stop taking this medication because it could result in worsening of hepatitis B infection. Option C is correct since abrupt cessation could result in a flare-up or reactivation causing hepatitis B to return in a worse way than before. Bone marrow suppression and worsened depression is routinely seen with pegylated interferon but not with either formulation of tenofovir. TDF may be taken without regard to meals or food requirements. TAF should be taken with food. Let's advance to the next slide, please. And the next question reads, which of the following clinical scenarios merits HCV screening? Is it A. An individual with hemophilia who received clotting factors in 1992, or B. An individual requiring a blood transfusion in 1996, or C. Individuals born after 1970, or is it D. Individuals with HIV co-infection? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Individuals with HIV co-infection. Option D is the best response since patients living with HIV carry a higher risk of co-infection. Option C is incorrect because the baby boomer population, date of birth 1945 to 1965, carry the highest risk of HCV, therefore, those born after 1970 do not carry as high of a risk. Option B is incorrect as individuals requiring blood transfusions prior to July 1992 carry the highest risk of HCV. Due to additional screening measures after July 1992, the risk became greatly reduced. Option A is incorrect as individuals receiving clotting factors prior to 1987 carried a great risk of HCV. Therefore, receipt of clotting factors after 1987 did not carry the same HCV risk. Kindly advance to the next slide. And the next question reads, which of the clinical scenarios listed below does not meet the criteria for initiation of HCV therapy? Is it A. a patient with HCV and metastatic HCC, or B. a patient with HCV genotype 1A and fibrosis score F0, or C. a patient co-infected with HCV, HIV, and HBV, or is it D. a patient with HCV and prior non-response to peginterferon and ribavirin? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. a patient with HCV and metastatic HCC. Option A is the best response. Due to a short life expectancy, the initiation of HCV treatment is not recommended. Option D is incorrect because prior non-response does not preclude a patient receiving HCV treatment. Levels of SVR are high and retreatment should be encouraged. Option C is incorrect because patients with co-infection should receive treatment as the risk of liver disease progression is often faster in this population. Option B is incorrect. Based on the AASLD guidelines, it is recommended that all patients be treated for HCV regardless of disease severity. Earlier treatment would reduce transmission along with progression of liver disease. Let's advance to the next question, please. And the next question reads, which of the regimens listed below would be the most appropriate to use in a treatment-naive patient DJL, who is non-serotic with HCV genotype 1b, HCV viral load 10,256,986 IU per milliliter on hemodialysis? Would it be A. Ledipasvir and sofosbuvir for 56 days, or B. Glecaprevir and P-brentasvir for 56 days, or C. Elbasvir and Grazoprevir for 56 days, or would it be D. Ribavirin plus sofosbuvir for 12 weeks? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Glecaprevir and P-brentasvir for 56 days. Option B is the best response since it is a preferred regimen in treatment-naive individuals with non-serotic genotype 1b infection. In addition, no dosage adjustments are necessary in hemodialysis. Option D is not a recommended regimen per the AASLD guidelines and a preferred option should be started initially. Additionally, there is minimal data to support usage of sofosbuvir in hemodialysis. Although Elbasvir and Grazoprevir may be an option in ESRD or hemodialysis, the duration of treatment should be 12 weeks. Although A is a recommended first-line option for this population, there is minimal data to support usage of sofosbuvir in hemodialysis. Additionally, treatment in the setting of the patient's viral load being above 6 million requires 12 weeks of therapy. Kindly advance to the next question, please. And the next question reads, GTM, a middle-aged treatment-naive patient with cirrhosis and HCV genotype 3, with an HCV viral load of 8,145,724 international units per milliliter, presents to your gastroenterology clinic seeking therapy for hepatitis. My question to you is, which of the regimens listed below would be the most appropriate to use in GTM's case? Would it be A. Ledipasvir and sofosbuvir for 56 days, or B. Glecaprevir and P-brentasvir for 16 weeks, or C. Sofosbuvir and velpatasvir for 12 weeks, or would it be D. Ribavirin plus sofosbuvir for 24 weeks? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Sofosbuvir and velpatasvir for 12 weeks. Option C is the best response since it is a preferred regimen in treatment-naive individuals with cirrhosis in genotype 3 infection. Option D is an alternative regimen per the AASLD guidelines and a preferred option should be started initially. Although Glecaprevir and P-brentasvir may be an option in patients with cirrhosis with genotype 3 infection, the duration of treatment should be 12 weeks. Option A is not recommended for genotype 3 virus since it is only indicated in all genotypes except 2 and 3. Kindly proceed to the next question. And the next question reads, WLK, a middle-aged patient is currently taking once daily bictegravir, tenofovir alafenamide and emtricitabine from your HIV comprehensive care clinic and would like to start treatment for the management of HCV. The patient is to start Glecaprevir and P-brentasvir. My question to you is, which of the regimens listed below would be the most appropriate recommendation for WLK now? Would it be A. Bictegravir, tenofovir alafenamide, and emtricitabine should be changed to abacavir, lamivudine and darunavir, cobicistat, or B. The patient may continue taking bictegravir, tenofovir alafenamide and emtricitabine while on Glecaprevir and P-brentasvir therapy, or C. Bictegravir and tenofovir alafenamide and emtricitabine should be held until HCV therapy is completed, or would it be D. Bictegravir should be changed to dolutegravir in order to avoid drug-drug interactions? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. The patient may continue taking bictegravir, tenofovir alafenamide and emtricitabine while on Glecaprevir and P-brentasvir therapy. Option B is the best response since there are no drug-drug interactions associated with these treatments. While dolutegravir may be safely used with glecaprevir, P. brentosvir, bictegravir may also be used safely with this combination for the management of HCV. ART should ideally never be interrupted during treatment. There are no known drug interactions between these combinations, so they may be safely administered together. The use of darunavir, cobicistat and glecaprevir with P. brentosvir is contraindicated. Therefore, these should not be given together. Kindly advance to the next question. And the next question reads, WVL, a middle-aged patient with decompensated cirrhosis and HCV genotype 1A was previously treated with SIM and SOF. Unfortunately, he experienced treatment failure. My question to you is, which of the regimens listed below would be the most appropriate therapy to initiate in WVL's case now? Would it be A. Elbasvir and grazoprevir for 24 weeks, or B. Sofosbuvir and velpatasvir with weight-based ribavirin for 12 weeks, or C. Ribavirin plus sofosbuvir for 12 weeks, or would it be D. Ladipasvir and sofosbuvir with low initial dose of ribavirin for 24 weeks? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Ladipasvir and sofosbuvir with low initial dose of ribavirin for 24 weeks. Option D is the best option since this is recommended as preferred therapy by the ASLD guidelines for the management of genotype 1A. Option C is not recommended in the setting of decompensated cirrhosis in those with previous SOF failure. Option B would be acceptable in the setting of NS5, a treatment failure with a duration of 24 weeks but not in the case of SOF failure. Option A is not recommended in this setting. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video.